Okay, guys, let's get started then. Okay, communication, right? That's where we are. So if you if you're on team 3 or 4, this is team 1, 2, and 5. If you are on team 3 or 4, you should be with Miss Deek and not with me. Okay. So if you were on team 3 and 4, you were with me yesterday. So if you're in the wrong spot, that's okay. Just tap out, go back to Zoom, and go back into the section you're supposed to be in. Okay. So so we're good to go. All right, communication. Let me get moving here. Okay, so communication is vital. Not only, I mean, it's very vital to just living, right? Just for us communicating and talking and helping each other out. But communication in nursing is so vitally important. There's so many things that we need to do. It promotes caring, concern, empathy, all of the things we do with nursing. We always have to be able to communicate and make sure that the patient and the family members understand what we're talking about. So it covers, when you look at related concepts on your SLO, it covers almost all 32 concepts in how we are to handle nursing. So what do we do? How does it affect nursing practice? We got to gather assessment data, right? Miss Deek was telling y'all add pi, right? Yesterday, in our nursing process, assessment is #1. So in order for us to get our assessment data and to communicate with our patient, we have to be able to converse with them, understand what they're saying. Do nurses teach? Absolutely. All the time we're teaching. We're going back in after the doctor leaves or the physical therapist leaves, and we're with that patient 12 hours. They are in there 5, 10, 15 minutes, maybe a half hour. When they leave, that patient needs probably has a lot of questions, probably has things they need clarified. So we're teaching, we're doing things. Do you think patients need to be persuaded? Do they want to get shots? Do they want to get IVs started? Do they want to take medicines? No, we have to kind of persuade them through teaching. What about collaboration? Healthcare professionals. Y'all all know about the doctors and you know about the other nurses and things like that. But what about the transport team? What about the people who clean the rooms? What about dietary? What about pharmacy? There are so many people we communicate with as a nurse because we are the center, we're the hub, we're the middle for everything comes through us, through the nurse. So we're communicating with a myriad of healthcare professionals. We advocate for our patients. So patients may need to go to hospice, they may need to go to home health care or something like this. So we advocate, we work with them, we move on. Caring, that's our main concern. One of our biggest theorists has their theories on caring. So y'all are gonna learn when you go to work on your BSN and you go to work on advanced degrees, you have theory, nursing theory. So you will get to meet a lot of the nursing theorists. And we have our nursing, caring is one of our big theories in nursing. And we're always providing comfort, keeping that patient comfortable. So we always going to have a definition for y'all. So it's a means of exchanging information or feelings between 2 or more people. So this is our definition, and it's our basic component of nursing. If we're not communicating properly, we're really not doing a good job with nursing. So here's our little stick figure. This isn't anything new. The sender sends a message. The receiver receives it and gives the sender feedback, letting them know what they receive. So sender, message goes across, feedback, back and forth between two individuals. So there are four modes we're going to talk about in communication: verbal, nonverbal, electronic, and written. Verbal and nonverbal been around a long time. Electronics kind of new in the business because we've got the electronic medical record now. And of course, written has been around also. So you're having to write properly. So verbal, first thing you got is your pace, your intonation, how we go, our rate, our rhythm, our tone. So when I walk in a room, I knock on the door. Hello, I'm Pete. I'm going to be taking care of you today. That's pretty nice, huh? Would you let Pete take care of you? Hopefully so. That was good. Okay, but what if I walk in and go, good morning, I'm Pete. I'm going to be taking care of you today. Would you want Pete to take care of you? Not so much. Same words, right? Same words. It's just how we approach them, right? So y'all know that. Y'all have, you know, you've taken care of people, you've talked to your husband, your wife, your kids, that words come out their mouth and you're like, that ain't even close, guys. Come on, get back with the program. What do you really want us to hear now? So simplicity, we need to avoid big medical terms. Y'all are nursing students. Yay, 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 good job. Y'all gonna know a lot of big words, okay? But the patient we need to use language they can understand, something that's age appropriate. I'm not gonna talk to a 20-year-old, 25-year-old person like I'm gonna talk to a 60 or 70-year-old person or 80-year-old person. I mean, it just doesn't work. LOL, BTW, all this stuff that y'all understand, us older people, we don't get it, right? I mean, that ain't, so we have to change gears. We have to use age appropriate terminology and avoid those medical terms because that's what doc uses. And, you know, I mean, let's put it in something they understand, okay? We gotta be clear. We gotta be direct. We have to enunciate our words. But we can't go in there and we know everything about CHF. Let me tell you about the flabby heart, and let me tell you about this. We have to be able to make it so they understand it, give them little chunks so that they can absorb it, digest it, and learn it, and then come back and teach again. It's got to be timely. It's got to be relevant, okay? We've got to go in there when the patient is ready to listen. If I walk in that room and the patient's eating breakfast and I'm like, good morning, how you doing? Oh, you eating breakfast? Eating is not a bad time to teach, but they may be watching the news. They may be watching their soap opera. They may be doing something else. It may not be the right time for us to teach that at that time. So we need to come in when the patient is ready to have that conversation, okay? We have to adapt, okay? So if I'm in there and I'm teaching and I'm talking to the patient and everything's going along fine, and then all of a sudden I'm picking up the patient is not, eye contact's not very good, they're kind of drifting away, their eyes are closing, they're getting tired. I have to take that nonverbal and say, hey, probably time to stop, guys. I'll come back a little bit later. We have to adapt, okay? Credibility. We are the most credible profession in the world. We're above everybody else. If you go out and ask, do you trust your doctor? A lot of patients will say yes, but they always trust us. They trust their nurses, okay? So, and that's because we need to be consistent. We need to be dependable and honest. Usually we are, okay? So that dependability, answering that call light, being there when they need us, answering the questions, you know, and being consistent in our care is so important. And humor, be positive and powerful. Focus on the positive. Make them laugh, make them happy, make them realize things are moving forward with them and they're doing better. Nonverbal, this is all the stuff we don't see. I mean, we do see, we pick up. In conversation, one of the problems we have with remote learning is you don't see me in front of the class now. You see me in my little picture on the side, but I'm not walking in front. I'm not looking at y'all. I can't see y'all. I'm losing 70% of communication by not being able to see my classroom. Y'all are losing 70% of my presentation by not seeing my hands move and my facial expressions and the things I do in front of the classroom. So only 30% is picked up verbally. That's why sometimes with remote learning, it becomes harder for students, because when a professor's lecturing, y'all pick up a lot of nonverbals. We pick up nonverbals from y'all, because I might talk about personal appearance and I can use an example in the classroom. Can't do that here, okay? So nonverbal's a big thing. So personal appearance, how we dress, our scrubs clean, is our hair nicely done, or, have we taken care of the things we do? Personal appearance is the first thing you see when you walk in that door. Your mama told you that, right? Look good, first impressions, right? So personal appearance is a big thing. Posture and gait, how you carry yourself, reflects your emotions, your attitude, your mood. If you walk into the room and you see a patient with their arms folded and their head down, and it's a dark room and it's kind of chilly in there, that tells you a lot about just how they look, how they feel, what they're doing, okay? So their posture, how they walk, how, what do they look like when you walk in that room? Facial expressions, okay? Facial expressions tell us a lot, How many of y'all have teenagers? A lot of y'all, right? How many of y'all are married, have boyfriends, girlfriends, whatever? You can tell what the day's gonna be like when that person walks in that kitchen for breakfast, and you're gonna go just looking at how their face is, and it's gonna tell you a lot. But for us, avoid shock or disgust or dismay in the presence of patients. So we go in, we look at that patient, we see they haven't eaten all their breakfast. We got to make sure our facial expression doesn't go, no, 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 you should be eating all of your meal. Why aren't you eating it? So don't try to avoid that, because they're going to pick it up from you. You're going to pick up a lot from them. And be careful to get good eye contact. Eye contact is so vitally important. So when you walk in that room, you make sure you're using that eye contact to connect with your patient. So be very, be very mindful of that. Gestures emphasize, they punctuate, they clarify things, or they may even stand alone. So like I'm saying, part of what you miss by not being in the classroom is the things that I'm doing with my hands, or the way my facial expressions that you don't get to see. So I'm half Italian. If you were to tell me that I couldn't use my hands, I wouldn't be able to talk. We'd be sitting here and you'd be going, Mr. Keller, and I'd be going, let me use my hands. So gestures mean a lot, okay? So be sure to, you'll pick up that in nonverbal. Okay, electronic is a newcomer to the crowd here. Its advantages, it's fast, it's fiction, it's legible, it's good documentation. It really improves communication, and it's very flexible, okay? Disadvantages are all the ones that we have over here. But I mean, when we're in school again, a lot of people are recording and doing things. So I'll sit down and I'll walk up in front of class and I'll hold up this device, a cell phone, and I'll say, whose cell phone? How much? $1,200, Mr. Keller. Okay. And then someone else has the little recorder, right? And this is a stapler. You can't see it, you see, but I'm holding something up and I'll go, how much is this little device? $35. Big difference, socioeconomic status, right? What can we afford? Electronics are very expensive. So we can have the biggest, fastest thing, or we might be down to just a basic component, okay? How many people still have flip phones? Probably not many, but we're not able to communicate tone, right? It's two-dimensional. It's the texting world that you got. Example I use is my daughter's a nurse practitioner up in Birmingham. She works at Children's Hospital. When she goes to work in the morning, she gets 3 devices. She gets a cell phone, she gets a tablet, and she gets a laptop. There are no nurses stations anymore at that hospital. Okay, it's been built in the last 4 years. Okay, everything is electronic. So when she goes in and does an assessment on a patient, she punches a little button on the wall and Siri comes on and says, hello, good morning. And she'll go, good morning, this is Marla. I'm taking care of patient Keller in room 352. And then she goes on with her assessment. She just dictates her assessment. When she finishes, she just goes back out, opens up her laptop and edits Siri's transcription into the medical record. Is that pretty cool? You don't have to type it out. It's all done. It's really nice, really good. When she needs the doctor to call her, she simply has to just dial up the number, punch a button on the phone, and boom, it goes out to the doctor's phone. Doctor calls her back. No secretary needed. Who called Dr. Jones? So things come back pretty quickly, pretty easily. So very, very nice. Very, very, very good. So Doc will listen, get the information, and Doc will say, I got it. I'm going to put the medication into Epic. It should be in the next 10 or 15 minutes. Call down the pharmacy in about a half hour, and medicine will be ready for you. So it's a good deal. Written communication, box 38.1. Remember, appropriate language and terminology. So if we're writing something to explain something to a patient, what level of development are they in? What's their educational level? What's their reading level? Y'all are gonna learn in teaching and learning that patients' reading level is about the 5th grade. So we can't get too excited about stuff we're writing for them. We got to take into account their culture. Where do they know what they're doing, how to do it? Now, when it comes to our writing, our documentation in the medical record, we need to make sure we use good grammar, spelling, punctuation. We need to make sure we're able to use the terminology properly. This is going to protect you from our friends on the billboards, Morris Bart and those guys, Dudley DeBosia, 4444444, right? I mean, these guys are after our licenses, okay? They want us. So what does an attorney do? They make you look incompetent, okay? That's their goal, is to make you find errors, find something wrong. If you have bad grammar, if you have bad spelling, if you're not using punctuation properly, or you're using inappropriate terminology, they're going to eat you alive on that stand. And they're going to make you look very bad. And then the jury's going to go, well, you must not be a good nurse because you can't spell. Spell check helps us, right? It's a good thing because I'm dyslexic. I misspell everything, okay? But spelling can be helped, but use proper grammar. And if you got a word that's 20 miles long and you don't know how to spell it, just use regular language to explain it. Use the definition. Don't try to be smart and put some term up there that you can't spell, okay? So logically organize things, start at the beginning and go to the end. If you're able to use examples, that's great. Keep it simple. And once again, my daughter has the cell phone. So when she's doing wound care, when she's got a wound on a patient, she takes a picture, it transposes into the medical record. Now she's gonna write, wound is 3 centimeters long, it's closed, it's approximated. She's gonna write a bunch of words, but a picture's worth 1,000 words, right? When someone actually sees that picture, sees that wound, it's so much better for people, okay? So use some pictures. And if you're going to be giving a presentation or someplace, make sure you use citations, resources, copyright things. We don't want to plagiarize anything. Okay, so factors. What are some of the factors? Okay, so we already kind of talked about the developmental things, right? So developmentally, where is that patient? Are they in their 20s, their 30s, their 40s? Are they married? Are they divorced? Do they have kids? Do they have people who are coming to visit them? Different things like that. So we have to assess that, right? We have to get that information, okay? Gender, that's just what it is. We talk differently, males to females, females to females, males to males. So if I'm taking care of a male patient, I'm going to have a bonding, a certain camaraderie because we are male to male. When I take care of a female, it's going to be a little bit different. When you guys take care of opposite sexes or same sexes, it's going to change the way we communicate, okay? Our values, our perceptions. So when we walk in that room and we see a little nightstand and there's a picture of the family and there may be a rosary beads, there may be a cross in the room or something, that gives us an idea of what's going on with that patient. You know, so the values, the perceptions we pick up on are big, okay? Personal space, very, very big, very, very big. So when we walk in the room, hi, I'm Pete, I'm taking care of you today. We're kind of in that public arena, 12 feet, you know, or beyond. We're just walking around the room, looking at everything. Then as we get closer and we start talking to the patient, we get into that social spot, which is 4 to 8 to 12 feet. Of course, in COVID, we're in that all the time, right? No closer than 6 feet. So that's where we live now in this social spot. But when we start to assess our patient, when we really want to talk to them, we need to get in that personal zone, 1.5 feet to 3 feet away. We don't want to be so far away in that 6 foot range. We want to get in that personal zone, 1.5 to 3 feet. And then when we get to the point that we've got to do our physical assessment, like Ms. Deek started with y'all yesterday and y'all are going to get next week, we need to get intimate. We need to be touching the patient or within 1.5 feet of the patient. So personal space is a big deal. Territoriality, I'm probably murdering all those syllables in there, but territory, okay? Now y'all are gonna learn real quick at nurses stations that when you see a purse or you see some gear sitting in front of a computer, that's a nurse's nest. We don't touch that nest. We leave that spot alone. But same thing in the rooms with patients, okay? So when we go in a room, in a patient's room, if they have the nightstand and they got their dentures there and their glasses and all, we're going in to do a wound change. So we walk in and we start moving their stuff off of the nightstand. That's not a good thing without getting permission. Maybe we can bring another nightstand in, or maybe we can bring equipment in that we need. But remember, respect that territory of the patient and your coworkers, right? What are the roles in relationship? Are they family members there? Are there siblings? What's going on in there? That's so important in understanding, because a lot of times we'll get information from those family members that'll help us to get a good outcome for that patient. What's the environment like? Is it hot? Is it cold? Is it sunny? Are the lights on? Is the air conditioning good? Do we have good ventilation? All of those things are components. Is it quiet? Is it comfortable for the patient? Congruence is, when you walk in, like I said, verbal, nonverbal, when that patient's sitting down there and you go, how you feeling today? Oh, I'm fine. Well, that pace, that tone, that intonation doesn't match to the words that came out of their mouth. Their nonverbals are not congruent. So if there's no congruence there, we have to dig deeper and find out what's going on. If the patient's not in the attitude or in the ready to learn, we have to adjust things again. We kind of talked about that. And then boundaries, y'all are gonna be taking care of patients 3 days in a row, 3 weeks in a row, 3 months in a row. And you're gonna get to know them. And you're gonna get pretty, you know, you're gonna be patients that you really, that's so nice, they're so good, and you just love them, okay? But you gotta keep your professional boundaries, okay? So, you know, we have to work within those parameters. So those are some of the factors that are there. Types of communicators, okay? We've got several types of communicators. They mainly located in 38.2, okay? So aggressive communicators, they are concerned about their own needs. They're concerned about themselves. They're concerned about, you know, what's going on with me. Passive communicators, on the other side of the coin, are people who are more about, you know, what's going on. You know, they're not too committed. They go with the flow. They're pretty easygoing, you know. So so we have those types of patients who are kind of listening to us and okay, that's okay. I'll be glad to eat. We'll do the things we have to do. And then assertive communicators are kind of in between the two. I mean, as a little aggressive, a little passive, but kind of between both of them. So they declare and they affirm. So we don't want to be too aggressive. We don't want to be too passive. You know, we don't want to, we want to be able to be assertive communicators. We want to be able to declare and affirm the things that need to be done with our patients.
Can you give an example of each? Because I'm still
Here we go, right here. Assertive communication. What we're going to look at is I statements, okay? So assertive, that would be like an aggressive communicator. I have done this assessment with you. I am getting ready to start the IV. I need us to get this done. So I statements, you know, assertive communication, but that's more aggressive, right? Because that's about me. So that's part of the aggressive part. Fogging is when you have the doctor and the nurse and they want the patient to get some sleep, let's say, okay? So we've got to become kind of a passive person with this one, right? A passive communicator, because guess what? Doc trumps the nurse, right? So now we take the role as a passive communicator. So Doc's saying, this patient hadn't slept in 3 days. I'm giving them Ambien and I'm gonna have them go to Betty Bye and I can put them down pretty easy. I'm gonna give them some Seroquel. Whereas the nurse, we know that the reason the patient's not sleeping is because of the noise, because of the things that are going on the unit, okay? So fogging is we both have the same goal, okay? In that we want the patient to sleep at night, okay? We may not go about it the same way, okay? So we have some independent nursing interventions we can do with the environment, making them comfortable, maybe giving them a shower before they go to bed at night. Maybe they're not getting that done. Before we go to the big atomic bomb, pull out the Seroquel or the Ambien or something like that, okay? Negative assertions. So negative assertions are lots of times people don't, you know, when you're in the hospital, you don't feel good. And so you go in with your aggressive communication style. We need to take a bath today. We need to do this today. I think we need this. And they come back at you and say, I'm not getting out of bed. I'm not eating. I'm not doing anything. Don't take it negative. We got to turn that around and make it positive. So assertive communicators do not take negative assertions badly. We take it as we've got to readdress it. How do we go about it? What do we have to get done? Okay. Repetition. Sometimes, once again, when you say something, people don't pick it up the first time. Might be the doctor, might be the pharmacist, might be physical therapy, might be dietary, might be the patient, okay? So sometimes we have to go back and change the way we say something, okay? Like the patient's not eating breakfast, you're talking to dietary. Okay, well, what do you want me to do? Well, the patient's not eating, what can we do? You know, and well, I mean, what do you want me to do? Well, I don't know, that's why I'm calling you, we need to figure this out. So you got to get a dialogue with them. So finally, when they come back and say, well, we have some options, we can do cereal, we can do this, we can do that. So repeating, clarifying, getting things on the same page sometimes needs to be done. Same thing with your patient when you go in there, okay? So use that in assertive. Confidence levels. We need to be confident, especially when y'all are students now, okay? So before we walk in the room and before you do anything in that room, you wanna, if you're not confident, you wanna go over it with your instructor and get things, get yourself comfortable before you go in there to do something, okay? Most nurses are confident, but from a student perspective, you need to get that confidence built up. So before you walk in the room, we will all work with you. We'll get you to that level, but get your confidence up. Assertive communicators are always confident. They're going to walk in there and not go, well, I kind of think. No, not wishy-washy. This is what we need to get done. This is what we need to do. Managing those nonverbals. Remember what I said, you know, if your facial expressions are off, or if your tone and intonation are off, and your nonverbal and your verbal communication are not congruent, then that patient's going to pick it up. So we have to be congruent. We have to understand that. So assertive communication is thinking before we speak. Once the horse is out the barn, we're in trouble, right? We can't bring it back in. So always think before you speak. Don't say something you shouldn't be doing, okay? We're gonna avoid apologies, okay? I'm not sorry I have to wake you up to give you your medicine. I mean, that's not it. I'm not, when I go in the room to do something, we're not gonna say, I'm sorry to bother you. You're gonna use those, you know, I'm here to give you a bath. Let's get up, let's get things done. We're here to eat today. So, I mean, so avoid apologies. You don't need to do apologies to the patient, because 9 times out of 10, when you're going in that room, it's for something to get them better, for a better outcome. And then after you've communicated and you're getting ready to leave, you want to ask, is there anything else you need from me? Is there any other questions I can answer for you? Is there anything we need to talk about or we need to cover? So you want to make sure you post conversation, you evaluate, and you close the loop, okay? You're closing the loop. Remember that feedback, message feedback? You're closing the loop with your patient to make sure that the conversation has been handled properly. Okay. Okay, so here we go with the nursing process. So assessment, the ADPI, right? That y'all, Ms. Deek introduced you to yesterday. Assessment for us now, every concept we have, you're gonna have to do part of a nursing, the ADPI, the nursing process. So how do we assess communication problems, okay? So first thing we look for are language deficits. Can the patient speak normally? Has the patient had a stroke? Has the patient have any other issues that help us, or deficits? Does the patient speak the same language as us? So any deficits that the patient has, we have to identify. Sensory deficits, that's our senses. Can the patient hear? Can the patient smell? Can the patient taste? Can the patient feel? Okay, so all of our senses help us. If the patient is blind, they lose a lot of nonverbal communication, right? So we have to adjust how we take care of that patient. They have sensory deficits. If they can't hear, we have to adjust how we're going, you know? If the patient can't move like they used to, we have to adjust how we take care of those patients. So those sensory deficits are very important. Remember, we can't give a diagnosis or a nursing problem unless we have an abnormal, okay? There's got to be abnormals for us to fix to be able to make a care plan. So we've got to have abnormal. So we've got to identify those issues. Cognitive impairments, anything that a patient, a patient could be demented and they can't speak as clearly. They can't express themselves. Sometimes with stroke patients, they're aphasic. They can't express themselves. So any cognitive impairments that they may have. Then we assess their verbal, nonverbal communication, okay? And this is pretty big with culture, okay? So, so what's the culture of the patient? Are they Eastern cultures? Are they Western cultures? We're going to do a whole concept on culture and sensitivity. So what are they? How are they taken care of? With people from the Middle East, I can't take care of a woman, okay, in a Middle Eastern country. If they're from one of those countries, I have been pulled off of that care for that patient because their culture won't allow me to do that. So they're verbal, they're nonverbal. How do we pick that up? And then basically all the way across the board, Maslow, okay? If they're hungry, if they're in pain, if they're short of breath, if they have fever, if they're nauseated, if it's too loud, patients can't focus. You can't focus. Just think about it. When you're hungry, can you study? No. If you're nauseated, do you feel like doing it? No. If you're in pain. So put yourself in the patient's position. So think about those things. So when we're assessing, we want to see if they have any of these things, we need to put that in our plan of care to fix before we can get good communication with our patient. And then developmental factors, you'll be taking care of people who have very little education. You'll be taking care of people who have a lot of education. We run into a lot of nurses we care for, a lot of physicians we care for. So highly educated people down to people who haven't even finished high school. So what are the developmental factors? Review the lifespan considerations in communicating with older adults, because a lot of times with level ones, we're going to be taking care of the elderly population, okay? So be sure to take a peek at that in the book. Okay, so here's our diagnosis. I know Miss Deek doesn't use diagnosis anymore. She uses some other word, but whatever it is, I didn't change my slide. So there are some diagnoses. All those diagnoses underneath there are potential communication diagnoses. But in order to give us a diagnosis, in order for us to do something, we've got to find abnormals. So what are defining characteristics? Those are abnormals, okay? Those are the things that they may have a deficit with that we're looking for. So do they have difficulty forming words, or they have difficulty articulating? Can they listen? Can they express themselves? Can they comprehend what's going on? Okay. So if they're missing any of those components, then we have the ability, those are abnormals, we have the ability to use these nursing diagnoses and make a good care plan for this patient concerning communication. So now we get into the planning part of the nursing process. So in planning, we set goals. We make the outcomes determinable. So we want to be specific. We want it to be measurable. So when we make a goal, we want the patient will initialize the conversation about their diagnosis by noon today, okay? So it's specific. Patient's going to verbalize about their diagnosis, and it's measurable from the standpoint that I know by noon today, that's my goal. is that they will be able to do the things that they need to do, okay? In a planning process, we normally have 2, 3, 4 plans of care going at one time. Which one is more important? Which one takes priority? You know, I mean, so y'all are gonna learn ABCs and everything. So if I have an oxygenation issue, or if I have a nutrition issue that the patient's not eating, or if I have the patient's not oxygenating well and short of breath, that's going to take a priority over a communication care plan, right? So we're going to have to fix some of these other things before our communication care plan kicks in. So we set priorities in planning. We figure out what needs to be done first. And then inside of an individual care plan, if we want that patient to be able to verbalize something about that diagnosis, we have interventions that we might have to prioritize to do first. First, we got to explain it. Then we got to give them a handout. Then we've got to be able to talk to the family members, blah, blah, blah. It comes down to priorities. And then we should always utilize teamwork and collaboration. So in communication, some of the people we lean on are interpreters. If that patient is speaking another language, speech therapists maybe can come in and help us. So look out there and see if there's anything that might be able to help us. Might be a family member, might be a priest, might be a pastor, might be someone who can help us with getting this patient to communicate better. So implementation, we're going to utilize therapeutic communication techniques. That's one of our exemplars, right? So we're going to talk about those communication techniques, and we're gonna dwell on those. We can adjust the environment. We talked about that, right? Whether it's hot, cold, bright, dark. Maybe they need an extra blanket, something like that. We provide support. We give them support just emotionally, by us answering those call bells, getting in there and talking to the patient. We can employ measures to enhance communication. So basically what that means is that, if a patient has trouble communicating verbally, maybe they need a dry erase board or a chalkboard or something, or a piece of paper and a pen in order to be able to communicate with us. So any measures that we need to use to help them to communicate, okay? And then finally, it's always about educating. So when we're implementing things, we want to make sure the patient and the family truly understand what we're doing. So when you're coming up with a care plan and you're looking at your care plan book, y'all will have a bunch of interventions that you'll be able to use to help that patient reach their goal. And then finally, evaluation. Evaluation is when we decide if the outcomes have been met. Have these outcomes been met, and have we accomplished what we wanted to do? So we're just evaluating the interventions. Were they effective? Was that patient able to talk to me about their diagnosis by noon? And do I feel like they understood what was being said? If I've met that goal, we're finished, we're done, that care plan's done. If I haven't met that goal, then I may have to readjust how I'm going to do things. Now I got to go back to say, maybe by 3 o'clock this afternoon, maybe by 5 o'clock, maybe after supper. Maybe they were a lot more with it today. They hadn't been eating, so they ate a little breakfast, they ate a little more lunch, so they're getting stronger. So maybe after supper tonight they'll be better. So we evaluate, we change our way our plan of care is being implemented. Okay, so table 26.3, these are the phases of our relationship. So let's just use a 12-hour shift as an example here. Pre-interaction phase, this is before meeting the patient. So most nurses, they'll get to the unit, they'll pull up, they'll look at their splits, they'll look at the patients, they'll get an understanding, they'll get in that medical record, and they'll kind of get an idea about what's going on, especially the first day they're taking care of these patients, these patient loads. Then they're going to go and they're going to get report from the nurse. Okay. So there's going to be an interaction before you meet the patient, that pre-interaction phase. Okay. The introductory phase is when I walk in, knock on the door. Hey, it's Pete. I'm coming to take care of you today. How you doing? What's going on? How was the night last night? You watched the Jazz lose the 7th in a row? Not the Jazz. What they played the Jazz. The Pelicans, they lost again, huh? And so we're going to kind of get in there, get some common ground, talk to him. I like to walk in and put my goals up on the dry erase board. I put my name, I put my Spectra link where they can get in touch with me. And I say, today we're going to eat breakfast, then we're going for a walk, then we're going to take a shower, then we're going to have this afternoon, we're going to try to go down to the windows and blah, blah, blah. We're gonna tell them our goals for the day in the introductory phase. Then the working phase, that becomes, here's your breakfast, here's your medicines, let's go for a walk, let's go take your bath, let's go do the things we gotta do today. So working phase extends, what, 10 hours of the day? You know, we got the rest of the day to work with them. And then around, an hour before we're leaving, we're gonna start the termination phase. So we're going to go in there and say, things are ending. Look at all the things we did today. Hey, you ate, you walked, you took your shower, or look at the things that we didn't get accomplished. You ate and you walked, but we didn't get to get that shower today. So I'm going to make sure the night nurse knows we got to get your shower taken care of. So in the termination phase, we're kind of wrapping up and telling them the things that we saw that were good and that we thought were good. Okay. And then what they need to fill in that night, maybe, because when I give that report to the nurse at night, that can be the beginning of their care plan for what they want to get done on that night shift with their patients. So this isn't any different. If you're a home healthcare nurse, it's going to be the same things. If you're in the clinic, it's just going to be a different environment. If I'm in a clinic and I'm only going to see the patient for maybe a half hour, 45 minutes, I'm going to do all of these different phases with them, but it's going to be a shorter time frame. It's going to be more compressed. Our care plan is going to be a lot simpler, right? Because it's not very complicated. So, but you're going to have all these phases of this relationship throughout the course of your care for the patient. Okay, so let's take a little break, about 5 minutes. So 5 minutes, and we'll be back at it again. Okay.
Okay.
Sounds good.
Okay, so let's go to our first exemplar, which is therapeutic communication. And here's our definition, okay? So it's an interactive process between the nurse and the patient. Could be the family, could be other things, okay? And it's to overcome stress. I also teach anxiety and stress that's going to be one of your last topics, So we want to get along with other people. We want to adjust to the psychological blocks that are out there, because this verbal thing, like Tara was sharing with us, thank you for sharing, Tara. If you weren't here to hear her problem, there's not a lot of a nurse can do interventionally, but put that patient at ease psychologically, right? So communication is really a lot of lowering your stress, lowering anxiety, having the patient feel better. How do we get that done? Okay. So it promotes understanding and helps us to establish that good relationship, that rapport we need. Okay. So we want to actively listen. Okay. In the classroom, I had a little thing I showed. It was a little Disney production, and it had Dumbo and some Disneyland people. But remember Dumbo? He's that elephant with those big floppy ears, right? Big
He
ears.
is
We have to
HSS
have
in the
big Dumbo
hospital, and
ears. We have to
the
listen to that.
doctor said that he's doing well. So
Please,
we're
someone is
just
not muted.
waiting to see
Please
how
mute.
he's doing later on.
Okay, sorry, I got that fixed. Anyway, big Dumbo ears, active listening, okay? So we have to be able to listen to what the patient is saying to us. So we've got to face the patient squarely, use an open posture, which means we can't have our arms folded. We've got to have our hands open. We got to be kind of reaching out to the patient, use that open posture, lean a little bit towards them. Lean a little bit in there so you're getting closer to them. Have good eye contact. The eyes are the window panes to the patient's soul, okay? So use that eye contact to get in touch with them. And you got to be relaxed, okay? Got to be relaxed. So active listening, SOLAR, S-O-L-E-R, SOLAR. That's the acronym that you may be seeing, okay? All right, so what are some of the techniques? Now that those two tables and those two boxes, those are important, guys. That's maybe 3 or 4 pages of examples and things like that. So familiarize yourself with that, because we know test questions are coming from these few slides. So make sure y'all get a good understanding of this, okay? So using silence. This is for a nurse, especially for Pete Keller, it is hard for me to be quiet. I like to talk, okay? I like to teach. I like to be engaged with my patient, okay? So me shutting up is hard, but I do it, and I need to do it more. But sometimes that patient needs to process everything. Like Tara was saying, Tara, I'm going to be using you a lot. I'm sorry, since you volunteered, but Tara was feeling bad. I mean, Tara needed more time to process stuff than a normal patient, okay? Because that Maslow wasn't being connected. So sometimes just using silent can be very therapeutic, okay? Especially if they just got bad news, okay? If we just had this done or we just had that done, and the prognosis is you're gonna have to be on antibiotics for the next 2 months, or something like that. Not even going to cancer, but I mean, we have other bad prognoses that can make you sad or something. So grief, patient could lose a limb and grieve. I mean, it's not like death, it's like losing a part of your body. So a lot of things come up with silence. With general leads, we don't want to generally lead them. We want to encourage verbalization. We don't want to say, you feel good, don't you? That's a general lead, okay? We're leading them. All they can do is say, yeah, what do you think? Duh, you're saying I feel good. So don't let them tell us, how are you feeling? Use those open-ended questions. Be specific. They've got to rate their pain. They've got to tell us how they're feeling. They've got to give us specific information for us to be able to take care of them. So we've got to drill down sometimes as nurses to pull it out of the patient to get those specific things. Use open-ended questions, okay? How are you feeling? I'd like to hear more about what happened today when you were in the operating room. Tell me more about this. Open-ended questions. Get those thoughts, their feelings, their emotions out. Get things that need to be done. Use of touch, okay? Once again, there's another theorist out there that we have that uses touch a lot, okay? So touch, we're human beings. We're sensate beings. We feel, okay? So touch is a big thing. So we need to it reinforces our feelings of caring. But we never can touch the patient without their approval. So we ask, and if we do use touch, we start from the side. We never look at them frontal, face to face. We come from the side, we touch their shoulder, maybe we rub the top of their shoulder, the top of their arm. That kind of makes them comfortable. Sometimes patients, especially older patients, will say, "Can you hold my hand?" Certainly, you can hold their hand if that's what they want. So, I mean, so the use of touch is very, very therapeutic. It's very good. Summarizing, this is, like I said, when we're in the termination phase, or maybe when we finishing up a teaching, we want to summarize and make sure we're evaluating if the patient got everything that we wanted them to get. So you can end the summarization with, "Tomorrow, we're going to continue where we left off. You got these 3 or 4 things done well today. We're in good shape." Okay. So we summarize. Clarification. Okay. We need to clarify things. So we can ask the patient to restate. We can ask them to explain it a little further. This is where those nonverbals come in. You look puzzled. Can you explain what's going on? Would you like to tell me some more about what's happened? Give me an example about how you're feeling, what's going on. Okay. So seek that clarification. Offering self. This displays interest and caring. So, I mean, this is a hard one too, because, we've got 5 or 6 patients normally on a unit. So when you say, "I'll stay here until we can get this problem taken care of. Let's work on this together. What can we do to get this done? I'll help you to fix this." Okay. So I'm offering myself. Okay. That's assertive. You're using those I sentences, but you're offering yourself and displaying interest and caring. Okay. And then giving information that's going to help them make decisions, lower their anxiety, feel safe, secure. It's essential to health education. So whoever walks in there, like I'm saying, could be dietary, physical assessment, speech therapy, occupational therapy, physicians, respiratory therapy. They're in there for a few minutes, okay? And, they're in there and they're using humor and they're talking and they're getting their interventions done, and they're mowing. They're getting out of there. They're leaving, okay? We got 5 patients. They may have 30 or 40, okay? So they get their stuff done, they move on. We go back in there and the patient needs things clarified. They need things addressed. So we need to help them. We need to give them information to help them lower that anxiety and help them with that. And then we're always looking for feedback. We need to get that feedback from the patient. So that's table 38.5. So take a look at that, and that should help. Okay. Some more here, sharing observations. Okay. So sharing observations are what we see. Now, I don't know if Ms. Deek talked about this, but in order for us to find those defining characteristics, to find those abnormals that are going on, we have to get data, right? So 2 types of data we obtain. We obtain subjective data, which is what the patient's saying. So when we're talking to them, they're going to be giving us subjective data. But objective data is what we see, what we observe, what we can see from the patient. So it's different from making assumptions. So I may walk in the room and I may see the patient pacing. "Oh, I see you're pacing." Pacing is not good unless they say, "Oh yeah, I'm getting ready to go walk. I just need to loosen up a little bit." Okay, well, that makes sense. Or an anxious patient may be pacing because they're anxious, right? "I just can't stay in the bed. I got to go for that procedure this afternoon, and I just don't know. I just got to get out of the bed. I feel like there's ants in the bed." So there's 2 different things, right? So we've got to share our observations. We walk in, that patient's got the covers pulled up to their top and they're shaking. "You're shaking." "Oh yeah, I feel like I got chills. I had fever last night." So we share our observations. Ask only relevant questions. Sometimes, I've been guilty of it too. I go in there and I start bombarding the patient. "What about this? What about that? What about this?" We got to get these things solved. I need to get this care plan together. Focus on one question at a time. Explore the topic fully and make sure you can close the loop on that topic. Then turn the page and go to the next thing. We don't need to do a whole chapter. Let's do page by page by page and close the loop on that. So ask your relevant questions one at a time and fully explore one topic before moving on. Sharing empathy. Empathy is what that patient is feeling, their reality, okay? So empathy is the feelings that that patient is having. So we need to draw out those feelings so that we can address them and help them, okay? Focusing is centering on the key elements, okay? So if that patient, when I say, it looks like you're shaking, and that patient reveals to me that they had fever and that they took some Tylenol and it broke the thing, but now they're feeling like, you know, they need some more Tylenol or something, that'll center us, right? That'll refocus us and get us moving in the same page and moving in the right direction. Okay. And then self-disclosure. These are personal experiences that we've experienced as nurses. Okay. So novice nurses, not so much. Y'all are still learning. But the more experienced nurses that are out there, you know, we've seen some things. So when a patient says, you know, oh my gosh, I just had my leg amputated. This is the end of the world. I'm going through their grieving process. After we get them over the grief and the hump, we start talking to them. Well, you know, I've taken care of many people who have amputated, you know, from their knee down. We can get this working. I've even got patients that are running marathons now. They're working out. Their life is good. We're going to get past that stage. We're going to get here. And then I can talk about their plan of care and move them forward. So kind of some self-disclosure types of things helps a lot. All right, barriers to communication. Okay, these are bad, right? These are the things we don't want to do. So that's 26.2 and 38.1 that you're looking at, okay? So we want to not do the probing. We don't need to ask irrelevant questions, okay? I don't need to know about the divorce. I don't need to know about the kid that failed out of LSU. I don't need to probe unless it really is something that is pertaining to the care of that patient. So no probing, no personal questions unless it's necessary for their care, okay? We don't need to ask for explanations. Why didn't you eat your breakfast? Why didn't you take your pills? Why aren't you doing this? That's putting the patient in a defensive posture. We're demeaning the patient. We're not going to ask for explanations. We're going to go in and say, hey, the bananas, we have bananas and cereal here this morning. I don't like bananas. Okay, well, that's why you're not going to eat it. I don't like Fruit Loops. Okay, what do you like? I like oatmeal and raisins. Okay, we'll fix it. Okay, but I'm not going to walk in and say, why are you not eating the banana and the Cheerios, you know? We don't give personal advice. We don't say, oh, don't worry about it. I take care of these guys all the time. You're not having any problems. You'll be fine, you know? So let's not give our personal opinions. If I were you, I would try to do this today. We want to find out what they want, what they need, what their opinion is, and what we need to do. Something that human nature, again, changing the subject. If we don't know an answer, a lot of times we just change the subject. A lot of times we just try to brush it aside because we're a nurse. We're supposed to know everything. If I don't know that answer, I just kind of brush it aside and move on to the next one because I know the next answer, okay? Don't do that. Just say, hey, I don't know. I'll have to find out about that. I'll look into that and I'll get back to you, okay? So don't change the subject, own it, go back out and find out about it. Usually there's someone on the unit, another nurse, your charge nurse, maybe your manager who has the answer for you. Maybe you got to call a doctor. Maybe you got to get on the phone and talk to the physical therapist or something. But you don't change the subject. Get the answer and go in there. Okay. No stereotyping. Okay. We can't stereotype. You know, all 2-year-olds are brats. Well, that's stereotyping. You know, that's not true. I have a lovely 2-year-old that's coming to eat supper tonight. You know, he's a brat, but I'm not going to stereotype him, right? But we don't want to stereotype, okay? So we don't do that, okay? We shouldn't be judgmental, okay? I mean, so we walk into the room and the patient's getting out of bed and they were told to have bed rest and to press the button, and they're getting out of bed to go to the bathroom. You know, you shouldn't be getting out of the bed without you know, permission. You know, they shouldn't be, but we don't want to be that judgmental. Maybe they forgot. Maybe they just got to go to the bathroom and they pressed the call light and no one came in. So we don't want to be judgmental. We want to find out why are you getting out of the bed? What's going on? I got to go to the bathroom. Okay. Did you press the call light? Yeah, no, that's been 10 minutes ago. Okay, well, that makes sense. Let's go. Come on, I'll help you to the bathroom. Let's get going. Okay. No unwarranted reassurances. You know, that's that big rubber stamp. Everything's going to be okay. Sure, for you, Pete, because in 3 or 4 days I'm going home, but I still got a scar that's 7 inches across the bottom of my belly, and I'm in pain, and da 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 da. So no unwarranted reassurances. No sympathy. You know, we understand that things happen. You lose limbs, you lose different things. You get bad prognoses. But we gotta get on the bright side. We gotta look at the things that are gonna make you feel better. With how are we gonna get better outcomes for you? And then these last two, I don't know what to tell you about those two. Defensiveness, we can't be defensive. I mean, patients are having bad days. Tara was telling you earlier, you know, she felt bad. You know, most patients feel bad. That's why they're in the hospital. They're not at the Hilton. They're not at the Marriott. You know, I mean, they're there because they're sick. They're not feeling good. Okay. So don't be defensive if the patient's a little, you know, barks at you or says something, and you can't argue with anybody. I mean, you really, argumenting is not something that, you know, it's not me against you and I'm going to win this conversation. That's arguing. We're not winning anything. Just step back, listen, put those big Dumbo ears out again, listen to what's going on. If you're mad, you got to self-contain, walk out of the room, blow some steam off, and try to look at it from the perspective of that patient, because more than likely, that is something that needs to be addressed, that we need to help that patient with. Okay, so another one of our exemplars is interviewing. Okay, interviewing and assessing are kind of the same things. Okay, so Ms. Deek's going to took you through vital signs and all assessments, and then she's going to do head to toe with you physical assessments. Well, with us, we're communicating, right? We're assessing through communication or interviewing, okay? So is the time correct, okay? Is it the correct timing? If the patient hasn't slept all night and they're not in good shape, do I want to walk in there at 7:15 and bubblehead my way through it? Oh, good morning, this is Pete. I'm in here, I'm not, you know, I'm going to take care of you. I'm not going to go wake them up. I'm going to go do other things. I'm going to go look at my other patients. I'm going to do some other things. Eventually, I'm going to have to go in that room, but might not be till 8 o'clock. I'm going to give them 45 minutes worth of sleep more, okay? So the timing has to be correct. The place, okay? So in the hospital, the place is the place, right? It's the room, okay? But, you know, what about a clinic? What about a home health agency nurse? What about hospice nursing? So place is a big thing with interviewing and with assessing patients. A lot of times when we do get into a hospice situation at the hospital and we're the person who's intervening, usually the hospice nurses come in and talk to them, but we may be trying to help those family members decide about that. So the place is probably not in the room with the patient to talk about that. You may be down the hall with the family members, right? So the place and that type of thing. Seating arrangement. You always want to be at eye level with the patients or the family members. So if they are standing up, if they're sitting down, you know, if they're in the bed, you got to bring the bed up higher. So how we adjust our connectivity, right? The way our face will interface with the other person we're talking to. We talked about distances, that social distance is where you need to be. And then we have to be able to talk in a tone and, you know, and use the verbiage that the patients and the family members are going to understand. So collecting data, we were talking about that, right? Objective data, okay? This is how we collect objective data. Table 34.2, we observe, we notice, it helps us select, organize, interpret. So that's the nonverbal stuff, right? That's 70% of what's going on. We used to go to the nursing home. I would take my students into different rooms and I would say they were all at breakfast. The patients were all at breakfast, the clients. And I'd say, what does this room tell you? There's a room with flowers and pictures and television and nice clothes and things like that. Go in another room, there's nothing in that room. You know, it's just a bed, a sheet, you know, and maybe a American flag on the wall. Well, that's a lady, that's a man. Okay, but it tells you a lot about a patient just walking in their room, okay? What we see, what we pick up, what we smell when we walk in that room. If I walk in that room and it's kind of right, it's not smelling right, maybe I better go check. Maybe someone had an accident, right? So my smell can tell me a lot. It could be a urine smell, it could be a feces smell, it could be a wound smell, right? So you'll get used to those things. It could be a sweet smell. What's happening? The feeding tube just became disconnected, and all the food's on the floor. It smells like sugar in that room. Okay, so smell helps us to do things. Hearing. There are a lot of noises in the unit. There are a lot of noises from pumps, from different things that are out there. So what we hear, what we see, and then of course, touch. We talked about that. We need to be good listeners. We need those Dumbo ears, right? We need to have that open and be listening to what that patient's saying. Do we listen only to patients? No, we listen to family members, right? But who else? We listen to physicians. We listen to physical therapy. We listen to pharmacists. We listen to everybody, okay? So speaking, listening, big deal when we collect data for patients, okay? And then when we use questions, we went over these different types of questions, the leading questions, you know, opening questions. So we're going to use open questioning as our go-to. We want them to tell us about something. So if I go in there and I'm doing my initial assessment and I go, hi, Mr. Keller, how you doing? I see you have hypertension. Can you tell me a little bit about it? Open question, right? Oh yeah, I've been diagnosed about 5 years. I take lisinopril, 25 milligrams 2 times a day. My blood pressures have been pretty good. They're running about 120/70. Okay, what more you want to know? Okay, or I could walk in that room with Mr. Keller, the demented patient, and say, hey, Mr. Keller, I see you have hypertension. Can you want to tell me about it? Yes. Can you tell me any more? I have hypertension. How long have you had hypertension? 3 or 4 years. Are you taking any medicines for your hypertension? Yeah, I take that little blue pill twice a day. And do you know what your blood pressure's running? Pretty close to normal, the nurse tells me, pretty normal. Now, those were all closed-end questions, right? There were one word, one answer, but I knew what I needed to get from my patient. So that's the only way as a nurse I could get that information. So if I can use open-end and they're going to give it to me, Hey, good job. If I need to go in and probe, I need to go in and use those things, okay? Neutral questions are kind of letting the, here you are, you come into the hospital, tell me what's going on. I mean, that's real wide open, right? Well, I have hypertension, I have COPD, I have kidney disease. They're going to tell you the whole story. So those neutral questions are pretty open and letting them go. We don't want to lead them though. No leading questions, okay? And then you want to kind of, nurses, as baby nurses, y'all are gonna walk around with pens and papers and stuff like that. You're gonna look at nurses, they just in that room with the patient, mentally retaining all this stuff. So you'll get to that point after you've practiced a while, you'll be able to take care of those types of things. So try to use that mental retention of your information.
Professor Keller, would you say it would be better to leave the question open, just walk in and say, good morning, how you doing? I understand that you have blah, 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 and then let them tell us or ask them, okay, I see that you're here, but it's saying that you have.
Always, yeah, open, you always try open first, but if you're not getting the information or if they're debilitated, you got to go to closed. So to get your information, but no, you want them to give you as much. Watch this here, okay? Interviewing techniques. Directive is nurse control, highly structured and specific, okay? So we know what we need to get from the patient. We know we got to get when were they diagnosed with hypertension? How long have they had it? What medicines are they taking? What's going on? We know we got to get that information. And so non-directive is they will volunteer it. They'll give it to us. They'll tell us what they need, then we need to know. But if we can't get it, then we're going to go to the specific questions. So those are the ways that you have to do it. But directive interviews, we control it. We absolutely know the information we need to get. Later on in the day, now that's pretty much like if you're taking care of a patient at the beginning of a shift, you're pretty much directing what's going on. But as the shift evolves during the day, it's going to become more non-directive and we're getting more feedback in from the patient. And when I walked in that morning and I put on, hey, I'm taking care of you. We're gonna eat breakfast. We're gonna go for a walk. We're gonna take a bath. When I go back in later and I say, okay, here's your breakfast and everything, and they go, I'm not hungry, I got to say, okay, but I feel like walking now. Okay, well, that's non-directive, right? They're giving me information. Well, I can say, look, I'm going to put your meal on the side. I'm going to tell dietary to leave it. Let's go for a walk. So we go take them for a walk and everything. And when they come back in, they go, can you go heat my breakfast up now? Sure. So we may have something in our head. We kind of directed it at 7:15 in the morning, and then 8:30, 9 o'clock, we're getting kind of feedback back from our patients, okay? But nurse interview, we got to get that information. We got to get the specific stuff we need. The non-directive is when we have that rapport established and that patient feels comfortable talking to us and giving feedback. Remember back about 15 slides ago, they got that feedback little component. Read about that in the book because that's important to get that feedback. Okay, these we kind of talked about, right? Open Den invites them to elaborate and illustrate their thoughts. Always our go-to questions, always the ones we want to use when possible. Closed End, when absolutely the only way we can get the information from them. Limits the answers to 1 or 2 words. And then neutral, patient can answer without direction or pressure. So like I said, what brings you into the hospital today? Well, I'm a diabetic. My blood sugar's been going up recently. I've been having the flu. I've been having a lot of issues. They're gonna kind of give you the general flow about what's going on. And leading, like I said, it's hard for the patient not to agree when we lead them down a path, and it's very non-therapeutic. But you have a lot of nurses that do that, and that's not something you want to do, okay? All right, so that's communication, and that's our topics for our exemplars and everything. So we're going to move on to team steps. Team steps is similar to BLS, ACLS, this type of thing. It's a certification that you're going to get, okay? And it was AHRQ and the Department of Defense and everybody was out there saying, how can we get healthcare, which is very complicated, a lot of moving parts? How can we get it streamlined? How can we get it to work better? So Team Steps was started about 30 years ago with the Department of Defense and did strategies and tools to enhance performance. So each semester you're at school, you're going to get 2 modules, okay? We're going to do 2 modules today. Next semester, you're going to get 2 more. Third semester, you get 2 more. Your final semester, you get 2 more. You have 8 modules. When you finish nursing school, you will become Team Step certified, which is great. And it's a good thing. So that's what Team Steps is. Okay, so before we start something, we got to figure out what's wrong, right? We got to find those abnormal things. So these are all the things that do not give us good team performance, the barriers, okay? So inconsistent team membership. When you work in a hospital, you know, how many nurses does that patient get when they're in that hospital? If they're there 3 or 4 days, it could be 3 or 4 nurses, okay? So consistency doesn't always, you know, work out, right? We've got, you know, doctors who, you know, who work with partners. They're not on call 24/7 anymore. So depending on the group that you're with, it depends on who's on call if you're not going to the office to see that patient. I mean, to see that doctor. And sometimes you can't even get in to see that doctor. You got to see one of their associates. So that's inconsistency in team membership. That's an obstacle. Lack of time. Do y'all have enough time to study and to work and to take care of your kids and everything? No. I mean, not in nursing school, right? We always have lack of time. I wish I could create time, but I can't, okay? Lack of information sharing, okay? So, you know, does dietary know everything the nurse knows about the patient? Does physical therapy know everything? No, so we have to share information, but how much do we share? How much time do I as a nurse have to share with all of these other parts of the healthcare system? The hierarchy. Is our hierarchy good? Okay, so we're only as good as our bosses. Our bosses are only as good as us. So as we go up and down the ladder, how good are our hierarchy, you know, building in the system now? Defensiveness, just human nature again. If someone comes to me and tells me something, most of the time people get defensive, okay? So we got to think about, we can't be defensive. We got to watch out for that. We've got to overcome that barrier, okay? Conventional thinking. Conventional thinking is, we've been doing this way forever. This is how we do catheter care. Well, this isn't the most recent way to do catheter care. You need to change the way you look at things, okay? So conventional thinking. We don't all communicate the same way. I mean, we were talking earlier about, you know, about remote learning and everything. Some people think this is the best thing since sliced bread. They really enjoy it. They have a good time with it. They think they learn well. Others can't stand it, you know? I mean, so varying communication styles. Conflict. There's not going to be, I'm going to guarantee you that when you work on a unit, you're going to have conflict with some people in that unit. You know, it's going to be Pete Keller, who, you know, he comes around and all he does all day is talk to me. I got to get away from him. We were at the nurses station the other day, and I mean, it was like 1 o'clock before I started my notes. He just doesn't shut up. I don't want to work with Pete, okay? So conflict, lack of coordination and follow-up, okay? So that's one of those things that we have to make sure we do. we're gonna get going, we're gonna be doing things, and the next thing you know, it's 6 o'clock, it's time for us to go home. 6 o'clock in the morning, 6 o'clock at night. Oops, I forgot to do this. Oops, I forgot to follow up with that. Oops, I promised the patient I was gonna do this. So we gotta remember, better coordination, better follow-up. We have to keep our distractions down. Fatigue. COVID-19 fatigue, my gosh, the workload that the nurses are under. We're losing nurses right hand, left hand, just because the workload has been so hard. And when you become fatigued and you're overworked, you're going to misinterpret the cues from your patients, okay? And then lack of role clarity, okay? A lot of times you'll get on a unit and you'll notice the unit secretary doesn't know what's going on. They don't understand what they're supposed to do. The charge nurse doesn't. So we've got to clarify roles, okay? So how do we get these done? So we've got to have a general knowledge, a shared mental model, okay? So a shared mental model is the model that the system puts out, Ochsner system, LCMC. They have a mental model that incorporates all of their facilities. So if you're in Ochsner, Kenner, and main campus, and West Bank, all of the hospitals have that same mental model. From that mental model, you get mutual trust and you get team orientation that comes into place. And then if those things are right, if that knowledge is there and the attitudes are correct, your performance is going to improve. So you're going to see good adaptability, better accuracy, good productivity, your efficiency goes up, and then finally safety. We always want to have good safety, okay? So high performing teams, they share that mental model, they have clear roles and responsibilities, okay? They share the same vision, okay? So a lot of times, when I was a director, I had to sit down and we had to have unit meetings, and my vision, my goal, my responsibility was what the administration was telling me, what my nurses were telling me were two different things, right? So I was caught in the middle. So I was the one who had to clarify these things. So that's where you have unit meetings and responsibilities to get the two to mesh, okay? So having clear shared vision, optimizing our resources, making sure we know everything. I mean, I was in charge of an ICU unit. I had stronger nurses than other nurses, right? So when I made schedules, I couldn't put all the weak nurses on the same shift, right? That ain't gonna work. I needed to intermingle my stronger nurses with my weaker nurses, okay? So strong leadership, that needed to be done. And then discipline, okay? When I had a nurse that didn't do something correctly, I needed to go across the board and discipline and get feedback from them. So if I had a seasoned nurse that was doing something wrong, that's not easy for a leader to go back and tell one of those nurses that's been there longer than me, they were doing something wrong. But I had to do that in order for when the weaker nurses did something wrong, I held them to the same standard. So everybody has to be at the same standard when it comes to discipline, okay? Strong set of collective trust. If you're doing these other things, you're gonna get trust, you're gonna get confidence. And then I always had an open door. I have an open door at school. If we need to talk, we need to communicate, call me, text me, email me, do something. Let's get on the same page. Let's not let it fester, and let's not get things done. So mechanisms to help that cooperation and coordination. And when you manage it, you get good outcomes. So team structure, you got to have a clearly defined team. You've got to understand how the teams interact, and you look for that implementing plan. You look for these things. So what are some things we can do to help with team structure? Here's our definition. It's two or more people interacting dynamically, independently, and adaptively before goals, okay? So, and it's usually time limited membership. So these are committees, these are things that are working together to try to get better outcomes. So partnering with patients, we need to involve the patients. This is a big thing. My daughter, one of my daughters, I have two. My daughter, my physical therapy daughter, got contracted Guillain-Barré, okay, 3 years ago, okay. That's a pretty scary thing, okay. So I had a strong, vibrant 30-something-year-old woman who played soccer and is a physical therapist on Sunday, walking around, talking, doing everything. She got admitted to the hospital Sunday. Wednesday, she couldn't get out of bed. All the nerve endings had been attacked by the virus, okay? So it was tough, okay? So I'm gonna use her as an example in this stuff here. So patients need to be included in bedside rounds. At the hospital we went to in Memphis, where she lives, the nurses and the doctors and everybody were right there. Bedside rounds, they talked to you, they included you right there, you will listen to. Handoffs were at bedside rounds, whether, like I said, physical therapists, anybody who was in there, everybody knew what was going on. We were all on the same page, okay? They provided patient with tools for communicating with the care team, okay? My daughter in Birmingham, when they press the call light, it rings their cell phone, okay? When my middle child, the one with Guillain-Barré, when we rang the call light, it went to a vibrate. They had a little, those little vibrating things like at the restaurant. It went there. It went to like a pager, I guess, and it put the room number or something. So they were pretty good. They came in, they did what needed to be done. This thing was a thing that, along with a lot of other things, but involved patients in key committees. So my daughter was in there for 8 weeks when she was in the hospital. She was in rehab for 16 weeks. And then when she got out of rehab, the team that was taking care of her got in touch with her and said, would you mind being on a committee to help us with other Guillain-Barré patients? Their outcomes have improved. She's been on that committee now for 2.5 years. Their outcomes have improved multifold, okay? Because of these involvements, okay? And getting patient participation. So Team Steps works. This concept is really, I teach it, I did it, I worked with it at the hospital, I implemented things, but this hospital, Southern Baptist in Memphis, really lived, they walked the walk and talked the talk. They did a good job. So the responsibilities, we need to listen to those patients. We need to look at their involvement. We need to ask patients about their concerns. One of the big things that came up, lidocaine patch. She had a lidocaine patch on her back. And Epic said you had to take it off every 12 hours. Well, she needed it on 24/7. So the first day she put it on at 2 o'clock in the afternoon, she got immediate relief. 2 o'clock in the morning, the nurse comes in and she says, I'm taking off the lidocaine patch. I said, you can't take off that patch. It's supposed to be on there all day. Doc wrote that order. No, he didn't. Epic tells us we got to take it off. So, well, you're gonna pay the price. Call the doctor. I'm not calling doctor 2 o'clock in the morning. Took that patch off. Within 30 minutes, she was in excruciating pain. Okay. That's been fixed by this committee, right? To fix that so that that doesn't happen anymore, okay? So getting feedback, getting relevant information, have those families proactive. My wife or I were at that bedside 24/7. She wasn't in the hospital. We were in the hospital 8 weeks too. No, you don't leave loved ones in the hospital, okay? Responsibilities of the family. We got to give them correct information. We got to stay with the prescribed plan of care. So the staff knew I was a nurse, knew my wife is a social worker. So when it came to things that needed to be done, I took care of certain things. They talked to me. They talked to my wife about comfort measures for my daughter. And so we worked together as a team. Voicing any concerns. If I had a concern, I'll let them know, okay? And they adjusted according to what we were looking at. and then looking for those changes in the patient's condition. Managing family members is always tough for nurses, okay? And then we got to follow those clinical teams. So effective communication is going to help us get through these things. Team steps is going to give us strategies and tools to execute this stuff. So if we implement the things according to team steps, we're going to get much better outcomes. So Joint Commission has found that 66% of sentinel events. What's a sentinel event? It's a bad thing, right? It's a real bad thing. So 70% of 66% are sentinel events were caused because of ineffective communication. Okay.
Events? I'm sorry. Can you like slow down when you say that word? I don't know what.
Sentinel events.
Yeah, what is a sentinel event?
Sentinel event is having the wrong leg cut off, having the wrong limb operated on, having something, given the wrong medication, patient dying. So sentinel events are bad things, okay? And Joint Commission comes in and looks at it, okay? So we're looking at things, it's not good, it's communication. We need to fix that. So how can, these are, Joint Commission came back and said, if your communication has all the relevant data, it's complete, it needs to be clear, it needs to convey information as is plainly understood, it needs to be brief, needs to be concise, and it needs to be timely, okay? So if we follow these standards of communication, we're probably gonna have much better outcomes. So we're going to look at 4 strategies to exchange information: SBAR, callback, checkback, and handoffs, okay? So those are the 4 strategies from team steps. So SBAR is a framework, it's situation, background, assessment, and recommendation. So basically, when we're dealing with SBAR, the situation, patient's name, date of birth, sex, what's their reason for being here? Do they have allergies? What's their code status? Any special needs, glasses, walkers, things like that. And briefly going over what the patient's background is. What the patient's condition is. Then background is that pertinent history. You know, do they have COPD? Have they had any other things going on recently? Any complications? Any history of falls? Are there any consults going on with the patient, okay? And then our assessment. Our assessment is basically the things we found abnormal when we were listening to the patient or when we did our assessment. Pain level, vital signs. You know, were there any things that we noted when we were doing our head to toe assessment that concerned us? And then finally, our recommendation. What do we want doc to give us in order for us to have things go well and change this, because this is a concern to us. So let me see if I can get this little vignette up.
Yes, this is Amy from 2 West. I've been taking care of Miss Everett.
Please mute your
She's
phone.
she's
Please
admitted
mute your box, please.
EDT.
She's on heparin, telemetry, and oxygen. She's been alert and pleasant with no problems other than urinary retention.
Okay, she has a Foley in place. But tonight she appeared confused. She's awake and oriented to person, but she thinks that she's at her aunt's house and that Ronald Reagan is president. Yeah, well, no, I checked with her nurse from the last
Few nights and confirmed that she doesn't sundown and she's normally very sharp. Her heart rate has increased to 110. Her blood
pressure is down to 110/60. Yeah, her systolic usually runs 150. Yes. Her temperature is 37 Celsius. She looks pale, but not uncomfortable.
her coag studies are within the parameters and her blood gas is normal. All other AM labs are normal.
And she's not putting out much urine, and it looks clouding me. I'm worried about her. I think she needs to be seen. Want me to order some labs?
Maybe send her urine for culture.
Yes, sounds like she could be getting septic. Send a urinalysis with culture, chemistries, and a CBC. Thanks for calling. I'm on my way, but I need to know if there are any changes immediately.
Okay, so that's SBAR. Pretty easy, pretty simple. We use this a lot, okay? We use this a lot in taking care of patients. So, so you'll be using it. You'll be going forward with it. So, so use your SBAR, okay? Call out is basically used in emergency situations where you have codes or you have something going on in the emergency room. So probably the vignette is real short here, but what it is they have a laboring woman who's having a baby, and the nurse is observing the heart rate of the baby, okay? And so the heart rate, that they're noticing that the heart rate is decelerating. The doctors are on the side looking at some other things, and she's calling out, Doc, the rate is down to 140. And Doc says, okay, thank you very much. And, you know, and they keep talking. We decelerated to 120. So she's calling out. She's saying, I'm concerned. There's a problem here. What can we do to fix this? We need to look at this. So a call out is noticing that something is needing to be addressed and that we need to let other team members help us to figure out what we're going to do next. Check back is basically when we get an order. In the days that we used to take phone orders and we needed clarification, Doc would say, okay, Pete, you asking for me to give you some higher dose of blood pressure medicine. Take the low pressure, bump it up to 50 milligrams, go from one time a day to 2 times a day PO, okay? So I got to close the loop and I say, okay, Dr. Phillips, thank you for that order. That was low pressure, 50 milligrams twice a day, PO, correct? Yes, that is correct. So we're checking back. We're feeding back in on the loop and closing the loop. So check back is clarifying and making sure we have our information together. And handoff is finally transferring information from transitions, okay? So whenever we receive patients or send patients away, so let's say I'm sending a patient to surgery, okay? So I'm gonna get a call from surgery saying we're ready to come pick up the patient. And I'm gonna give that nurse who's gonna take care of that patient in pre-op a report. Well, that's Mr. Jones. He has normal saline going at 150. He's got pain to the lower left quadrant, blah, 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 blah. I'm gonna give her all that information. They're gonna come up, they're gonna pick the patient. Pre-op nurse is gonna get them ready for surgery. When they're finished, they're gonna hand off to the operating room nurse, okay? So the operating room nurse gets a report from the pre-op nurse, takes care of the patient during the procedure. Doc finishes, procedure's done. They're gonna hand off to post-op nurse. Post-op nurse gets the report from the operating room nurse, takes care of the patient, patient's recovered. Post-op calls back up. Hey, Pete, ready for Mr. Jones to come back up. Surgery was fine, everything's good. She's on 150 milliliters lactated ringers. He's gonna finish this bag, then he's go back to normal saline. We're gonna get report back from that nurse. So in a 2 or 3 hour time frame, that patient handed off to 4 different, we had 4 different handoffs for that patient and what was going on with that patient. So it's transferring responsibility. We clarify information. We let the verbal communication work because we got to talk to him. Acknowledgement from the receiver. So we got feedback going back and forth. And always give the person who you're giving report to the opportunity to review and to ask questions. That's vitally important. And so finally, what you're going to get with team steps, so these barriers stay the same. They never go away. The outcomes are always the same. These are the things we always want, but we're filling our toolbox here with tools and strategies. So today we learned about communication, SBAR, callback, checkup, checkback, and handoff. If we use these communication tools, we will probably have much better outcomes. So that's what Team Steps is all about. So these tools and strategies, this little toolbox here will continue to grow as we go through. Okay, guys, well, that's it. We are done.
I do have a question, Mr. Keller.
Okay.
Example, a patient is in the room crying. What do you do? What is the best? What is the best?
What do you do? Tell me what you do. What would you do?
Well, definitely probably not ask what's wrong.
Why not? What kind of question you can use?
An open-ended question.
Open-ended question.
Come in,
right?
introduce yourself, and say, "Do you want to talk to somebody?"
Yeah, I mean,
you
open-ended.
can ask,
You
like,
go in
what's-
there and you start
Like,
probing it.
What's your concerns? Or
Yeah, I
what
mean-
could be bothering you?
Is there anything I can do to help?
Yeah, those types of things.
Mr. Keller, I have a question too.
Okay.
In that video, when they were giving the order over the phone from the
Uh-huh.
doctor, is that the proper way, or do you need to get another nurse to back up that order?
No, it's proper. I mean, and once again, like I'm saying, electronic world, that doctor's going to Epic now.
Okay, because she was at home, so I was wondering.
Right. But this is older, right? This is back
Okay.
in the day when we got our stuff from the doctors, right? But nowadays, Doc's gonna probably put it straight back in to say, okay, that's fine. I'm gonna order these lab. They're gonna tell us what they're ordering, right? I'm gonna order a CBC, a BMP, this kind of thing. I'm gonna get this. I'm gonna do that. I'm gonna come up and see her. I'm putting that all into Epic right now.
Okay.
More than
So-
likely, but in the day, or if they don't have Epic or they don't have electronic medical record, that was the proper way. You don't need another nurse to listen to the conversation.
Okay, so once you've given the order, you don't need to verify it because you got it from the doctor.
Correct.
Thank you very much.
Okay.
You verify it with the doctor if you can.
Well, I mean, we're good with that. Okay. Let's not complicate it.
Keller, I have a question too.
Okay.
What if you're having difficulty with the patient to establish the
Having difficulty what?
rapport with them, report the trust?
Rapport? Having difficulty with rapport? Is that what you're saying?
Yeah, like with the nurse and the patient.
I'm still not understanding you. Speak up.
With the nurse and the patient, what if you're having difficulty forming that with them?
Like Tara? Did you hear what Tara had with her nurse? Right. I mean, so all you can do with, if you're having difficulty having a good rapport with your nurse, with the nurse, you as a patient, it's your responsibility to go to the charge nurse. Okay, and to get someone who you can establish a good rapport with. You have responsibilities just like the nurse has responsibilities.
What if it was like vice versa and the nurse is having trouble with the patient? Then, I mean,
They're gonna talk to the charge nurse and say, it ain't working. I gotta get away. If I don't, I'm gonna kill this patient. I mean, we say that to people, because it does happen, I'm being facetious in one sense, but you gotta have good rapport. If the patient doesn't have good rapport, you don't have good rapport, not a lot you can do about it. You gotta change gears and get somebody who can help you. Okay? All right, guys. Thank y'all.
I have a question before you leave.
Okay.
I'm having trouble finding my book.
Finding
Like
the
I've been
book.
trying to, been trying to get it online. Went to Delgado, they don't have it. They said they should be getting a digital copy in. I'm gonna try again
Carl
today.
Pearson.
Pearson.
Call him.
Okay.
My mom called, I know, wow, I sound like such a child, but oh well. My mom called Pearson and like spent a bunch of time with customer service and was able to get it.
Yeah, Carl
I was
Pearson.
busy at work.
Yeah.
Okay. But yeah, customer service, and it ended up happening. It just took an annoying wait time, but
She actually got to talk to someone, Alexandra, because every time I've called, I haven't gotten someone.
yeah.
No, you'll get them. You gotta
Again,
have
like, she
patience.
had it a whole day off. She just worked on it for me because I was being a person, and I'm really lucky to have the best mom ever. I mean,
Professor, are we finished? Because I have.
We done. We done.
Okay.
Okay, guys, see y'all later. Have a
Well,
good
Dr.
weekend.
Keller.
Bye-bye.
I had a question, unless you wanted to leave.
Well, a lot of people want to leave, but go ahead.
Before you, make sure you put your number.
Well, if you don't
Yeah,
want to
we
go
got
anywhere,
that.
I just had a question for you.
Go ahead.
So let's say it's about communication and religion. So if you're in a patient's room and you all are having a conversation, and then they bring up their religious beliefs, and let's say you have different religious beliefs or you're not that religious, but it would make them feel better if you shared the same views. Is it better to not be honest in that aspect and say that you agree with them, or is it better to not comment on that?
No, you have to be truthful. You have to be faithful to your own feelings and to the patient's feelings. Like I told you, I can't take care of Middle Eastern women. I mean, their religion won't allow it, okay? So, I mean, if there are views that are contraindicated between your views and the patient's views, and you're being asked to do something you don't feel comfortable with, you need to go to your charge nurse and say, doc has asked, the orders of this, I don't feel comfortable because of my religious views, okay? So if you're taking care of a patient like a Jehovah's Witness who doesn't take blood products, we have to treat the patient according to their views. We can't change it. I mean, the Middle Eastern woman doesn't want a man taking care of her. We've got to honor their cultures, their religions, the things that they have going on. But if we have a conflict personally about any type of procedure that we don't feel comfortable with because of our religious views, then we need to talk to our boss, which would be the charge nurse, and say, I don't feel comfortable doing that. That answer your question?
Yes, sir. Thank you.
Okay. All right.
Y'all make your number next to your section. It really does make it easier for roll.
Yeah, looks like most of them have, so. All right, see y'all later. Have a good weekend.
I think because every time you turn on your screen again, your name with the number is not going to be there. So the students have to remember to put their number because it's not going to show up. And it happened to me. I mean, it was only my name and I had to put my number again. Every time I have to do that.
Every time you log in, right? That's what you're saying.
Yes, every time I log in, I have to
So
add
don't
my
assume,
number.
what you're saying is don't assume next Thursday that your number is gonna be there.
Yes, sir.
Okay. All right, we clarified, right? We closed the loop on that one.
Yes.
All right, guys. Thank y'all.
Thank you very much.
Bye-bye.